Postoperative care. Many of the effects and potential complications of surgery identified in this chapter are discussed as clinical problems in other chapters. In addition, the problems in nursing care related to specific surgical procedures are discussed in the appropriate chapters of the text. Care in the PACU. The postoperative period begins immediately after surgery and continues until the patient is discharged from medical care. Nursing care is protecting patient and preventing complications while the body is repaired. The PACU is located adjacent to the operating room. This location minimizes transportation of the patient immediately after surgery and provides ready access to anesthesia and surgical personnel. 3 phases of post-anesthesia care provide different levels of care depending on the wide variety of patients' needs, includes types of surgeries, surgical settings, and levels of anesthesia. How patients move through the phases of care in the PACU is determined by their condition. Phase 1. Care during the immediate post-anesthesia period, ECG and more intense monitoring. The goal is to prepare patient for transfer to Phase 2 or inpatient unit. Phase 2. Ambulatory surgery patients, and goal is to prepare patient for transfer to extended observation, home, or extended care facility. PACU progression. If a patient assigned to Phase 1 care on admission to the PACU is stable and recovering well, the patient may rapidly progress through Phase 1 to discharge to either Phase 2 care or an inpatient unit. This accelerated progress is called rapid post-anesthesia care unit progression. It can occur with inpatients or with outpatients. Another accelerated system of care is fast tracking, which involves admitting directly to Phase 2 care ambulatory surgery patients who have received general, regional, or local anesthesia. Fast tracking decreases overall recovery time, length of hospital stay, hospital costs, and medical morbidity. Although this can potentially result in time and cost saving, the patient's safety should be primary determining factor of where or at what level postoperative care is provided. Phase 1 Initial Assessment. During the initial assessment, identify signs of inadequate oxygenation and ventilation. Any evidence of respiratory compromise requires prompt intervention. A temperature of 100.8 in the first 48 hours is usually caused by atelectasis, and the person should have the patient cough and deep breathe. Care in the PACU. Initial assessment is airway patency, rate and quality of respirations, auscultate breath sounds in all fields. Initial assessment, ECG monitoring, initiated for cardiac rate and rhythm. Note differences from preoperative findings. Measure the blood pressure and compare with baseline. Assess temperature and skin color and condition. Any evidence of inadequate circulatory status requires prompt intervention. Recent observational studies suggest that transcutaneous carbon dioxide pressure monitoring is a more sensitive indicator of respiratory depression. A slight drop in postoperative blood pressure with a normal pulse and warm, dry skin indicates normal response to the residual effects of anesthesia and requires only ongoing monitoring. Hypotension with tachycardia and/or cool, clammy skin would suggest hypovolemic or hemorrhagic shock and the need for notification of the anesthesia care provider, increased fluids, and high concentration oxygen administration. Assessment of urinary system should review input and output and fluid balance. Assess surgical site and condition of dressing and note amount and type of drainage. Goal is to identify actual and potential problems. After assessment, continue to apply the skills of assessment, diagnosis, and intervention. Assessment of the urinary system focuses on intake, output, and fluid balance. Intraoperative fluid totals are part of the anesthesia report. You should note the presence of all intravenous lines, all irrigation solutions and infusions, and all output devices, including catheters and wound drains. Postoperative orders related to incision care are instituted. All data obtained in the admission assessment are documented in the PACU record, a form specific to post-anesthesia and post-surgical care. The goal of PACU care is to identify actual and potential patient problems that may occur as a result of anesthetic administration and surgical intervention and to intervene appropriately. Initial neurological assessment explain all activities starting with admission. Sensory and motor blockade may be present in patients who have had a regional anesthetic. The patient may be awake, drowsy but arousable, or asleep. Because here it is the first sentence to return in an unconscious patient, you should explain all activities to the patient from the moment of admission to the PACU. Potential problems in the postoperative period. The most common causes of airway compromise: obstruction, hypoxemia, hypoventilation. Patients at particular risk include those who receive general anesthesia, are older, smoke tobacco. Patients at particular risk include those who have lung disease, are obese, undergo thoracic, airway, or abdominal surgery. However, respiratory problems may occur with any patient who has been anesthetized. Airway obstruction, blockage of airway by patient's tongue, supine position, extremely sleepy patient. The base of the tongue falls backward against the soft palate and includes the pharynx. It is most pronounced in the supine position and in the patient who is extremely sleepy after surgery. Causes and relief of airway obstruction from patient's tongue. Hypoxemia, PaO2 less than 60 millimeters of mercury, ranges from agitation to somnolence, hypertension to hypotension, and tachycardia to bradycardia. Arterial blood gas used to confirm if pulse oximetry is low. Pulse oximetry will indicate low oxygen saturation, 90 to 92%, and arterial blood gas analysis should be used to confirm hypoxemia if the pulse oximetry indicates a low oxygen saturation. In an unconscious postoperative patient, a likely cause of hypoxemia is airway obstruction by the tongue, and the first action is to clear the airway by maneuvers such as the jaw thrust or chin lift. Increasing the oxygen flow rate and suctioning are not helpful when the airway is obstructed by the tongue. Elevating the patient's head will not be effective in correcting the obstruction, but may help with oxygenation after the patient is awake. Atelectasis. Postoperative atelectasis. We look at A, it's the normal bronchiole and alveoli. B is the mucus plug in the bronchiole, and C is collapse of alveoli due to atelectasis following absorption of air. Atelectasis is the most common cause of postoperative hypoxemia. May result from bronchial obstruction from retained secretions or decreased respiration. Atelectasis, alveolar collapse, may be the result of bronchial obstruction caused by retained secretions or decreased respiratory excursion. It may also result from general anesthesia administered during surgery in combination with high levels of supplemental oxygen. Atelectasis occurs when the mucus blocks the bronchioles or when the amount of alveolar surfactant, the substance that holds the alveolar open, is reduced. As air becomes trapped beyond the plug and is eventually absorbed, the alveoli collapse. Atelectasis may affect a portion or an entire lobe of the lungs. Common causes of respiratory problems for postoperative patients in the clinical unit are atelectasis and pneumonia, especially after abdominal and thoracic surgery. The postoperative development of mucus plugs and decreased surfactant production are directly related to hypoventilation, constant recumbent position, ineffective coughing, and history of smoking. Increased bronchial secretions occur when the respiratory passages have been irritated by heavy smoking or acute or chronic pulmonary infection or disease, and by the drying of mucous membranes that occurs with intubation, inhalation anesthesia, and dehydration. Without intervention, atelectasis can progress to pneumonia when microorganisms grow in the stagnant mucus and an infection develops. Pulmonary edema is caused by accumulation of fluids in the alveoli, can result from fluid overload, left ventricular failure, or prolonged airway obstruction, sepsis, or aspiration. Characterized by crackles, decreased compliance, or infiltrates on X-ray. Aspiration of gastric contents can cause potentially serious emergency, may cause laryngospasm, infection, and pulmonary edema. The prevention is the goal. Bronchospasms may be due to aspiration, endotracheal intubation, suctioning, or chemical mediator release as a result of an allergic response. Bronchospasm may occur in any patient but is seen more frequently in patients with asthma and chronic obstructive pulmonary disease. Hypoventilation may occur from depression of the central respiratory drive and/or poor respiratory muscle tone. Sign and symptoms: a decreased rate of effort, hypoxemia, and increase in the PaCO2. Respiratory complications. Observe the chest wall for symmetry of movement with the hand placed lightly over the xiphoid process. Impaired ventilation may initially be detected by the observation of slowed breathing or diminished chest and abdominal movement during the respiratory cycle. Also determine whether abdominal or accessory muscles are being used for breathing. Observable use of these muscles may indicate respiratory distress. You should auscultate breath sounds anteriorly, laterally, and posteriorly. Decreased or absent breath sounds will be detected when airflow is diminished or obstructed. Regular monitoring of vital signs with pulse oximetry. Note the characteristics of the sputum. One characteristic of ineffective airway clearance is the presence of adventitious breath sounds such as rhonchi or wheezing, so clear breath sounds are an indication of resolution of the problem. Spirometer use and increased fluid intake are interventions for ineffective airway clearance but may not improve breath sounds in all patients. Elevated temperature may occur with atelectasis, but a normal or near normal temperature does not always indicate resolution of respiratory problems. Because of the patient's assessment indicates physiologic stability, the most likely cause of the patient's agitation is emergent delirium, which will resolve as the patient wakes up more fully. The nurse should ensure patient safety through interventions such as raising the bed rails, securing IV lines. Emergent delirium is common in patients recovering from anesthesia. Nursing implementation. Proper positioning to facilitate respirations and protect airway. Lateral position unless contraindicated. Patient allowed in supine position with head of bed elevated once conscious. In the PACU, nursing interventions are designed to prevent and treat respiratory problems. Proper positioning of the patient to facilitate respirations and protect the airway is essential. Once conscious, the patient is usually returned to the supine position with the head of the bed elevated. This position maximizes expansion of the thorax by decreasing the pressure of the abdominal contents on the diaphragm. Respiratory complications. Oxygen therapy will be used if the patient has had general anesthesia and the anesthesia care provider has ordered it. Oxygen therapy is given nasal cannula or face mask. The use of oxygen aids in the elimination of anesthetic gases and helps meet the increased demand for oxygen resulting from decreased blood volume or increased cellular metabolism. If the patient requires postoperative breathing assistance, a mechanical ventilator will be provided. Deep breathing is encouraged to facilitate gas exchange and to promote the return to consciousness. Once the patient is more awake, deep breathing and coughing techniques help the patient prevent alveolar collapse and move respiratory secretions to larger airway passages for expectoration. Encourage the patient to breathe deeply 10 times every hour while awake. The use of the incentive spirometer is helpful in providing visual feedback of respiratory effort. Diaphragmatic or abdominal breathing involves inhaling slowly and deeply through the nose, holding the breath for a few seconds, and then exhaling slowly and completely through the mouth. The patient's hand should be placed lightly over the lower ribs and upper abdomen. This allows the patient to feel the abdomen rise during inspiration and fall during expiration. Effective coughing is essential in mobilizing secretions, so if secretions are present in the respiratory passages, deep breathing often will move them up to stimulate the cough reflex without any voluntary effort by the patient, and then they can be expectorated. Splinting an abdominal incision with a pillow or a rolled blanket provides support for the incision and aids in coughing and expectoration of secretions. You should change the patient's position every 1 to 2 hours to allow full chest expansion and to increase perfusion of both lungs. Sitting in a chair and ambulation should be aggressively carried out as soon as physician approval is given. Provide adequate and regular analgesic medication because incisional pain often is the greatest deterrent to patient participation in effective ventilation and ambulation. Also reassure the patient that these activities will not cause the incision to separate. Adequate hydration, either parenteral or oral, is essential to maintain the integrity of mucous membranes and to keep secretions thin and loose for easy expectoration. The patient should initially be positioned in the lateral recovery position to keep the airway open and avoid aspiration. The prone position is not usually used and would make it difficult to assess the patient's respiratory effort and cardiovascular status. The Trendelenburg position is avoided because it increases the work of breathing. The patient is placed supine with the head elevated after regaining consciousness. Splinting with a pillow or blanket. And this picture lists the techniques for splinting incision when coughing. Potential cardiovascular problems. Hypotension is evidenced by signs of hypoperfusion to the vital organs, especially the brain, the heart, and the kidneys. Clinical signs of disorientation, loss of consciousness, chest pain, and oliguria reflect hypoperfusion, hypoxemia, and loss of physiologic compensation. Interventions must be timely to prevent the devastating complications of cardiac ischemia or infarction, cerebral ischemia, renal ischemia, and bowel infarction. The most common cause of hypotension in the PACU is unreplaced fluid and blood loss, which may lead to hypovolemic shock. Hemorrhage is always a risk for surgery. Marked blood loss is possible when cauterization or sutures fail. Hemorrhage most often occurs internally, requiring assessment for changes in level of consciousness and vital signs. If changes are detected, treatment will be directed toward restoring circulatory volume. If no response to fluid administration occurs, cardiac dysfunction should be considered the cause of hypotension. Hypertension may be seen as a result of revascularization during surgery. Potential cardiovascular problems, dysrhythmias, hypothermia, pain, surgical stress, and many anesthetic agents are also capable of causing dysrhythmias. In the clinical unit, postoperative fluid and electrolyte imbalances are contributing factors to cardiovascular problems. Some imbalances may develop as a result of a combination of the body's normal response to the stress of surgery, excessive fluid losses, and improper IV fluid replacement. The body's fluid status directly affects cardiac output. Fluid retention results from the secretion and release of two hormones by the pituitary antidiuretic hormone and the adrenocorticotropic hormone, and from activation of the renin-angiotensin-aldosterone system. Antidiuretic hormone release leads to increased water reabsorption and decreased urinary output and increased blood volume. Adrenocorticotropic hormone stimulates the adrenal cortex to secrete cortisol and, to a lesser degree, aldosterone. Fluid losses resulting from surgery decrease kidney perfusion, stimulating the renin-angiotensin-aldosterone system and cause marked release of aldosterone. Both the mechanisms that increase aldosterone lead to significant sodium and fluid retention, increasing blood volume. Fluid overload may occur during this period of fluid retention when IV fluids are administered too rapidly, when chronic, an example, cardiac renal disease exists, or when the patient is an older adult. Fluid deficits from untreated preoperative dehydration, intraoperative blood losses, or slow or inadequate fluid replacement can lead to decreases in cardiac output and tissue perfusion. Postoperative losses from vomiting, bleeding, wound drainage, or suctioning can contribute to fluid deficits. Hypokalemia can be a consequence of urinary and gastrointestinal tract losses, and it occurs when potassium is not replaced in IV fluids. Low serum potassium levels directly affect the contractility of the heart and may contribute to decrease in cardiac output and tissue perfusion. Replacement of potassium is usually 40 milliequivalents a day. However, potassium should not be given until renal function has been assessed. Urine output of at least 0.5 mL per kilogram per hour is generally considered indicative of adequate renal function. Cardiovascular status is also affected by the state of tissue perfusion or blood flow. The stress response contributes to an increase in clotting tendencies in the postoperative patient by increasing platelet production. In addition, general anesthesia causes peripheral vasodilation, which may contribute to damage of the vascular lining. Venous thromboembolism may form in leg veins as a result of inactivity, body position, and pressure, all which lead to venous stasis and decreased perfusion. Venous thromboembolism, which is especially common in older adults, obese individuals, and immobilized patients, is a potentially life-threatening complication because it may lead to pulmonary embolism. Patients with a history of venous thromboembolisms have a greater risk for pulmonary embolism. Pulmonary embolism should be suspected in any patient complaining of tachypnea, dyspnea, and tachycardia, particularly when the patient is already receiving oxygen therapy. Other manifestations may include agitation, chest pain, hypotension, hemoptysis, dysrhythmias, and heart failure. Superficial thrombophlebitis is an uncomfortable but less ominous complication that may develop in a leg vein as a result of venous or in the arm veins as a result of irritation from IV catheters or solutions. If a piece of a clot becomes dislodged and travels to the lungs, it can cause a pulmonary infarction of the size proportionate to the vessel in which it lodges. Syncope, or fainting, is another condition that reflects cardiovascular status. It may indicate decreased cardiac output, fluid deficits, or defects in cerebral perfusion. Syncope frequently occurs as a result of postural hypotension when the patient ambulates. It is more common in the older adult or in a patient who has been immobile for long periods of time. Normally, when the patient quickly moves to a standing position, the arterial baroreceptors respond to the accompanying fall in blood pressure with sympathetic nervous system stimulation, which produces vasoconstriction and thereby maintains blood pressure. These sympathetic and vasomotor functions may be diminished in the older adult and the immobile or post-anesthetic patient. The most important aspect of cardiovascular assessment is frequent monitoring of vital signs. They are usually monitored every 15 minutes in phase 1 or more often until stabilized, and then at less frequent intervals. Compare postoperative vital signs with preoperative and intraoperative readings to determine when the signs are stabilizing at a level that is normal for the patient. Cardiac monitoring is recommended for patients who have a history of cardiac disease and for all older adult patients who have undergone major surgery, regardless of whether they have cardiac problems. Assess the apical radial pulse carefully. Report any deficits or irregularities. Assessment of skin color, temperature, and moisture provides valuable information in detecting cardiovascular problems. Hypotension, accompanied by a normal pulse and warm, dry, pink skin, usually represents the residual vasodilating effects of the anesthesia and suggests only a need for continued observation. Hypotension, accompanied by a rapid pulse and cold and clammy, pale skin, may indicate impending hypovolemic shock and requires immediate treatment. Nursing diagnosis: think of decreased cardiac output, deficit fluid volume, excess fluid volume, ineffective peripheral tissue perfusion, activity intolerance. Collaborative problems would be potential complication, hypovolemic shock, and venous thromboembolism. Treatment of hypotension should always begin with oxygen therapy to promote oxygenation of hypoperfused organs. Blood pressure measurement errors should be ruled out and volume status should be assessed. Inspect the surgical incision to determine if excessive bleeding is the cause of volume loss. Because the most common cause of hypotension is fluid loss, IV fluid boluses will be given to normalize blood pressure. Primary cardiac dysfunction may require drug intervention. Peripheral vasodilation and hypotension may require vasoconstrictive agents to normalize systemic vascular resistance. An accurate intake and output record should be kept during the postoperative period, and lab findings, electrolytes, and hematocrit should be monitored. Nursing responsibilities related to IV management are critical during this period. In particular, you must be alert for symptoms of too slow or too rapid rate of fluid replacement. Ongoing assessment of the potential complications associated with the IV administration of potassium, which is a life-threatening cardiac dysrhythmia, and also pain at the infusion site is essential. Early ambulation is the most significant general nursing measure to prevent postoperative complications. The exercise associated with walking increases muscle tone, improves GI and urinary tract function, stimulates circulation, which prevents venous and venous thromboembolism and speeds wound healing, and increases vital capacity and maintains normal respiratory function. Current recommendations for the venous thromboembolism for patients who undergo a major surgical procedure include pharmacologic prophylaxis with low molecular weight heparin or low-dose unfractionated heparin. Recommendations for patients with multiple risk factors for the development of a venous thromboembolism: non-ambulatory, elderly, history of venous embolism, include the use of low molecular weight heparin or low-dose unfractionated heparin in combination with intermittent compression devices. Patients who are at high risk for bleeding should use intermittent compression devices until the risk for bleeding decreases. Once the risk for bleeding has decreased, drug prophylaxis may be added or substituted. You may prevent syncope by making changes slowly in the patient's position. Progression to ambulation can be achieved by first raising the head of the patient's bed for 1 to 2 minutes and then assisting the patient to sit with legs dangling while monitoring the pulse for rate and quality. If no changes or complaints are noted, start ambulation with ongoing monitoring of the pulse. If the changes in the pulse are noted or dizziness occurs, sit the patient in a nearby chair or ease the patient to the floor. The patient should remain in this location until recovery is evidenced by blood pressure and pulse stability. Then help the patient back to the bed. Potential neurologic problems. Postoperatively, emergent delirium is a neurological alteration that causes the greatest concern. Emergent delirium, or waking up wild, can include behaviors such as restlessness, agitation, disorientation, thrashing, and shouting. This condition may be caused by anesthetic agents, hypoxia, bladder distension, pain, residual neuromuscular blockade, or the presence of an endotracheal tube. If delirium occurs, first suspect hypoxia. The most common cause of delayed emergence is prolonged drug action, particularly of opioids, sedatives, and inhaled anesthetics, as opposed to neurological injury. Normal awakening can be predicted by the anesthesia care provider based on the drugs used in surgery. Emergent delirium may be caused by a variety of factors. However, the nurse should always first assess for hypoxemia. 2 types of postoperative cognitive impairment are seen in surgical patients: postoperative cognitive dysfunction and delirium. Postoperative cognitive dysfunction is a decline in cognitive function like memory, ability to concentrate, for weeks and months after surgery. Postoperative cognitive dysfunction is almost exclusively seen in the older surgical patient. Age, duration of anesthesia, intraoperative complications, and postoperative infections are related to the development of postoperative cognitive dysfunction. Postoperative delirium is also more common in the older patient, but it can occur at any age. Delirium may arise from a variety of psychological and physiologic factors, including fluid and electrolyte imbalances, hypoxemia, drug effects, sleep deprivation, sensory deprivation, or overload. It is characterized by cognitive dysfunction, varying levels of consciousness, altered psychomotor activity, and a disturbed sleep-wake cycle. Anxiety and depression may also occur in postoperative patients. Any patient may experience these responses as part of grieving for lost body parts or functions or for decreased independence during the recovery and rehabilitation process. Radical surgeries leading to changes in body function or surgical findings that suggest a poor prognosis may cause more pronounced psychologic reactions. Alcohol withdrawal delirium occurs as a result of alcohol withdrawal in postoperative patient. Alcohol withdrawal delirium is a reaction characterized by restlessness, insomnia, and nightmares, irritability, and auditory or visual hallucinations. The nurse's initial action should be to assess exactly the patient's concern about self-care. Referral to home health and assessment of a patient's support system may be appropriate actions, but will be based on further assessments of the patient's concern. If the neurological status is altered, try to determine possible causes. If the patient was mentally alert before surgery and becomes cognitively impaired postoperatively, you should suspect delirium or postoperative cognitive dysfunction. The most common cause of postoperative agitation in the PACU is hypoxemia. As a result, focus your attention on evaluating respiratory function. Once hypoxemia has been ruled out as a cause of postoperative delirium and all potentially known cases have been addressed, sedation may be beneficial in controlling the agitation and providing for patient and staff safety. Emergent delirium is usually time-limited and will resolve before the patient is discharged from the PACU. Because the most common cause of delayed emergence is prolonged drug action, delays in awakening usually spontaneously resolve with time. If necessary, benzodiazepines and opioids may be reversed with drug antagonists. Until the patient is awake and able to communicate effectively, it is your responsibility to act as a patient advocate and to maintain patient safety at all times. This includes having the side rails up, securing IV lines, and artificial airways, verifying the presence of identification and allergy bands, and monitoring physiologic status. To prevent or manage postoperative cognitive delirium, you need to address factors that are known to contribute to the condition. Maintenance of normal physiological function is important and includes fluid and electrolyte balance, adequate nutrition and sleep, pain management, proper bowel and bladder function, and early mobilization. You can also use specific aids such as clocks, calendars, and photographs to help orient the patient. You should attempt to prevent or limit psychologic problems in the postoperative period by providing adequate support for the patient. This includes listening to and talking with the patient, offering explanations and reassurance, and encourage the presence and assistance of the patient's caregivers. You must observe and evaluate the patient's behavior to distinguish a normal reaction to a stressful situation from one that is becoming particularly abnormal or excessive. The recognition of alcohol withdrawal delirium presents a particular challenge. Immediately report any unusual or disturbed behavior so that diagnosis and treatment may be instituted. You should discuss the patient's expectations regarding activity and assistance needed following discharge. The patient and the caregiver must be included in discharge planning and provided with information and support to make informed decisions about continuing care. Postoperative pain is caused by the interactions of a number of physiologic and psychologic factors. The skin and underlying tissues have been traumatized by the incision and retraction during surgery. In addition, reflex muscle spasms may occur around the incision. Anxiety and fear, sometimes related to the anticipation of pain, create tension and further increase muscle tone and spasm. Positioning during surgery or the use of internal devices such as an endotracheal tube or catheters may also result in pain. The effort and movement associated with deep breathing, coughing, and ambulating may aggravate pain by creating tension on the incision area. When the internal viscera are cut, no pain is felt. However, pressure in the internal viscera elicits pain. Therefore, deep visceral pain may signal the presence of a complication such as intestinal distension, bleeding, or abscess formation. Pain can contribute to complications such as dysfunction of the immune and coagulation systems and delayed return of normal gastric and bowel function. It also increases the risk of atelectasis and impaired respiratory function. The patient's self-report is the single most reliable indicator of pain. Because this is not always possible in the PACU, the patient should also be observed for other indications of pain: restlessness, changes in vital signs, diaphoresis. Identifying the location of the pain is important. Incisional pain is to be expected, but other causes of pain, such as full bladder, may also be present. The most essential nursing action and encourage these postoperative activities is administration of adequate analgesia to allow the patient to accomplish the activities with minimal pain. Even with motivation provided by proper teaching, positive reinforcement, and concerns about complications, patients will have difficulty if there is a great deal of pain involved with these activities. The most effective interventions for postoperative pain management include using a variety of analgesics. IV opioids provide the most rapid relief. Drugs are administered slowly and are titrated to allow for optimal pain management with minimal to no adverse drug side effects. More sustained relief may be obtained by using epidural catheters, patient-controlled analgesia, or regional anesthetic blockade. During the first 48 hours or longer, opioid analgesics like morphine are required to relieve moderate to severe pain. A combination of two analgesics, an opioid and a nonsteroidal inflammatory drug, may be used to provide the lowest dose of medication and to limit side effects. After that time, non-opioid analgesics such as nonsteroidals may be sufficient as pain intensity decreases. Postoperative pain relief is your responsibility because the surgeon's order for analgesic medication and other comfort measures are usually written on as an as-needed PRN basis. For some patients, orthopedic, warmed IV fluids are used. Postoperatively, these patients demonstrate higher core temperatures, a decrease in shivering, and shorter recovery time. Complications be compromised immune function, postoperative pain and shivering, increased bleeding, untoward cardiac events, altered drug metabolism, and impaired wound healing. Shivering can increase oxygen consumption, carbon dioxide production, and cardiac output, as well as significantly affect a patient's comfort level. For hypothermia, passive rewarming raises basal metabolism. Active rewarming requires application of warming devices: blankets, heated aerosols, radiant warmers, forced air warmers, or heated water. Monitor body temperature at 30-minute intervals when using an external warming device. Care should be taken to prevent skin injuries. Provide oxygen therapy for increased demand. Oxygen therapy via nasal prongs or mask is used to treat the increased demand for oxygen accompanying the increase in body temperature. Shivering is usually quickly suppressed by opioids like Demerol. Wound infection is often accompanied by a fever that spikes in the afternoon or evening and returns to near normal levels in the morning. The respiratory tract may be infected secondary to stasis of secretions in areas of atelectasis. The urinary tract may be infected secondary to catheterization. Superficial thrombophlebitis may occur in the IV site or in the leg veins. Thrombophlebitis in the leg veins may produce a temperature elevation between 7 and 10 days after surgery. Hospital-acquired infectious diarrhea caused by Clostridium difficile may be signaled by fever, diarrhea, and abdominal pain. Surgical patients who receive antibiotics for a period of time are at risk for Clostridium difficile infections. Intermittent high fever accompanied by shaking, chills, and diaphoresis suggests septicemia. This may occur at any time during the postoperative period because microorganisms may have been introduced into the bloodstream during surgery, especially in GI or genitourinary procedures. Septicemia may also occur later from a wound or urinary tract infection. Frequent assessment of the patient's temperature is important to detect patterns of hypothermia and/or fever that may be present in the postoperative period. Temperature may be taken orally, temporally, or via the tympanic membrane. The color and temperature of the skin should also be assessed. You should observe the patient for early signs of inflammation and infection that may precede a fever so that any complications that arise may be treated in a timely manner. You should question the patient about feelings of nausea. If vomiting occurs, it is important to determine the quantity, characteristics, and color of the vomitus. Assess the abdomen for distension and the presence of bowel sounds. Because bowel sounds are frequently absent or diminished in the immediate postoperative period, auscultate all 4 quadrants to determine the presence, frequency, and characteristics of the sounds. In addition to normal bowel sounds and the absence of distension, the return of normal bowel motility is usually accompanied by the passage of flatus. Postoperative nausea and vomiting remain the most common postoperative complication. GI problems are responsible for unanticipated hospital admission of day surgery patients, increased patient discomfort, delays in discharge, and patient dissatisfaction with the surgical experience. Numerous risk factors have been identified by the development of nausea and vomiting. These include gender, female, history of motion sickness or previous postoperative nausea and vomiting, action of anesthetics or opioids, and duration and type of surgery. Delayed gastric emptying and slow peristalsis that results from handling of the bowel during abdominal surgery also contribute to nausea and vomiting, as does the resumption of oral intake too soon after surgery. Abdominal distension is another common problem caused by decreased peristalsis. This can occur as a result of handling of the intestine during surgery and limited dietary intake before and after surgery. After abdominal surgery, motility in the large intestine may be reduced for 3 to 5 days, although motility in the small intestine resumes within 24 hours. Swallowed air and GI secretions may accumulate in the colon, producing distension and gas pains. Hiccups, syngultus, are intermittent spasms of the diaphragm caused by irritation of the phrenic nerve which innervates the diaphragm. Postoperative sources of direct irritation of the phrenic nerve may be gastric distension, intestinal obstruction, intra-abdominal bleeding, and a subphrenic abscess. Indirect irritation of the phrenic nerve may be produced by acid-base and electrolyte imbalances. Reflex irritation may come from drinking hot or cold liquids or from the presence of a nasogastric tube. Hiccups usually last a short time and subside spontaneously. Occasionally, there may be persistent, but they are rarely debilitating. Postoperative nausea and vomiting are treated with the use of antiemetic or prokinetic drugs. In the PACU, oral fluids should be given only as indicated and tolerated. IV fluids will provide hydration until the patient is able to tolerate oral fluids. Care should also be taken to prevent aspiration if the patient vomits while still sleepy from anesthesia. To protect the patient from aspiration, position the patient in the lateral recovery position and have suction equipment readily available at the bedside. Depending on the nature of the surgery, the patient may resume oral intake as soon as the gag reflex returns. The patient who has had abdominal surgery is usually allowed nothing by mouth until the presence of bowel sounds indicates the return of peristalsis. When the patient is NPO, IV infusions are given to maintain fluid and electrolyte balance. A nasogastric tube may be used to decompress the stomach to prevent nausea, vomiting, and abdominal distension. Regular mouth care is essential for comfort and stimulation of salivary glands when the patient is NPO or has a nasogastric tube. When oral intake is allowed, clear liquids are offered first and the IV infusion is continued, usually at a reduced rate. If oral intake is well tolerated, the IV infusion is discontinued and the diet is advanced until a regular diet is tolerated. Abdominal distension may be prevented or minimized by early and frequent ambulation, which stimulates intestinal motility. Assess the patient regularly to detect the resumption of normal intestinal peristalsis as evidenced by the return of bowel sounds and the passage of flatus. The nasogastric tube must be clamped or the suction turned off when the abdomen is auscultated. Resumption of a normal diet after bowel sounds have returned will also enhance the return of normal peristalsis. The patient may need to be encouraged to expel flatus and assured that expulsion is necessary and desirable. Gas pains, which tend to become pronounced on the second or third postoperative day, may be relieved by ambulation and frequent repositioning. Positioning the patient on the right side permits gas to rise along the transverse colon and facilitate its release. Bisacodyl or Dulcolac suppositories may be ordered to stimulate colonic peristalsis and expulsion of flatus and feces. A T-tube normally drains dark green to bright yellow drainage, so no action other than to document the amount and color of the drainage is needed. Low urine output 800 to 15 mL in the first 24 hours after surgery may be expected regardless of fluid intake. The low output is caused by increased aldosterone and ADH secretion resulting from the stress of surgery, fluid restriction before surgery, and fluid loss through surgery, drainage, and diaphoresis. By the second or third day, the patient will begin to have increasing urinary output after fluid has been mobilized and the immediate stress reaction subsides. Acute urinary retention can occur in the postoperative period for a variety of reasons. Anesthesia depresses the nervous system, including the micturition reflex arc and the higher centers that influence it. This allows the bladder to fill more completely than normal before the urge to void is felt. Anesthesia also impedes voluntary micturition. Anticholinergic and opioid drugs may also interfere with the ability to initiate voiding or to empty the bladder completely. Retention is more likely to occur after lower abdominal or pelvic surgery because spasms or guarding of the abdominal and pelvic muscles interferes with their normal function and micturition. Pain may alter perception and interfere with the patient's awareness of bladder filling. Voiding ability is probably impaired to the greatest extent by immobility and the recumbent position in bed. The supine position reduces the ability to relax the perineal muscles and external sphincter. Oliguria can be a manifestation of renal failure and is less common, although more serious problem after surgery. It may result from renal ischemia caused by inadequate renal perfusion or altered cardiovascular function. The initial action should be to assess the bladder for distension. If the bladder is distended, providing the patient with privacy will be helpful. Catheterization should only be done after other measures have been tried without success because of the risk for urinary tract infection. You can facilitate voiding by normal positioning of the patient, sitting for women and standing for men. Provide reassurance to the patient regarding the ability to void. The use of techniques such as providing privacy, running water, have the patient drink water, or pouring warm water over the perineum can help. Ambulation, preferably to the bathroom, or the use of a bedside commode is an additional helpful measure to assist in voiding. The surgeon often leaves an order to catheterize the patient in 6 to 8 hours if voiding has not occurred. Because of the possibility of infection associated with catheterization, you should first try to validate that the bladder is actually full. In assessing the need for catheterization, consider fluid intake during and after surgery and determine bladder fullness by palpable fullness above the symphysis pubis and discomfort when pressure is applied over the bladder or the presence of the urge to void. A portable bladder ultrasound may be performed to assess volume of urine in the bladder and avoid unnecessary catheterization. If catheterization is required, a straight catheterization is preferred to limit the possibility of infection associated with the procedure. Surgery generally involves an incision through the skin and underlying tissue. An incision disrupts the protective skin barrier. Wound healing is one of the major concerns during the postoperative period. An adequate nutritional state is essential for wound healing. Amino acids are readily available for the healing process because of the catabolic effects of the stress-related hormones like cortisol. The patient who is well nourished preoperatively can tolerate the postoperative delay in nutritional intake for several days. However, the patient with pre-existing nutritional deficits that occur with chronic diseases like diabetes, ulcerative colitis, or alcoholism is more prone to problems of wound healing. Obesity affects abdominal wound healing. Wound healing is also a concern for the older adult. The patient who is unable to meet nutritional needs postoperatively may be provided with enteral nutrition or parenteral nutrition to promote healing. Wound infection may result from contamination of the wound from three major sources: exogenous flora present in the environment and on the skin, oral flora, and intestinal flora. The incidence of wound sepsis is higher in patients who are malnourished, immunosuppressed, or older, or have been a prolonged hospital stay or a lengthy surgical procedure lasting greater than 3 hours. Patients undergoing bowel surgery, particularly after traumatic injury, are at particularly high risk. Infection may involve the entire incision and may extend downward through the deeper tissue layers. An abscess may form locally, or the infection may spread throughout entire body cavities, as in peritonitis. Evidence of wound infection usually does not become apparent before the 3rd to the 5th postoperative day. Local manifestations include redness, swelling, and increasing pain and tenderness at the site. Systemic manifestations are fever and leukocytosis. An accumulation of fluid in a wound may create pressure, impair circulation and wound healing, and predispose to infection. For those reasons, the surgeon may place a drain in the incision or make a stab wound adjacent to the incision to allow for drainage. These drains may be made of soft rubber and drain onto a dressing, or they may have firm catheters attached to a hemovac or other source of gentle suction. Nursing assessment of a wound and dressing requires knowledge of the type of wound, the drains inserted, and expected drainage related to the specific type of surgery. A small amount of serous drainage is common from any type of wound. If a drain is in place, a moderate to large amount of drainage may be expected. For example, an abdominal incision with an accompanying drain is expected to have a moderate amount of serosanguinous drainage in the first 24 hours. In contrast, an inguinal herniorrhaphy should only have minimal serous drainage during the postoperative period. In general, drainage is expected to change from sanguinous, which is red, to serosanguinous, which is pink, to serous, which is clear yellow. The drainage output should decrease over hours or days depending on the type of surgery. Wound infection may be accompanied by purulent drainage. Wound dehiscence, which is separation and disruption of previously joined wound edges, may be preceded by a sudden discharge of brown, pink, or clear drainage. When drainage occurs on the dressing, note and record the type, amount, color, consistency, and odor of drainage. Also assess the effects of position changes on drainage. Notify the surgeon of any excessive or abnormal drainage or significant vital signs. The incision may be covered with the dressing immediately after surgery. If there is no drainage after 24 to 48 hours, the dressing may be removed and the incision left open to the air. If the initial operative dressing is saturated, institutional policy determines whether you may change the dressing or simply reinforce it. When the dressing is changed, note the numbers and types of drains present. Care should be taken to avoid dislodging drains during dressing removal. When the dressing is changed, the incision site should be examined carefully. The area around the sutures may be slightly reddened and swollen, which is an expected inflammatory response. However, the skin around the incision should be more of a normal color and temperature. Clinical manifestations of infection include redness, swelling, pain, fever, and increased white blood cell count. If healing occurs by primary intention, little or no drainage is present, and no drains are in place, a single-layer dressing or no dressing is sufficient. A multi-layer dressing is used when drains are in place, when moderate or heavy drainage is occurring, or when healing occurs other than primary intention. The choice of discharge site is based on patient acuity, access to follow-up care, and the potential for postoperative complications. The decision to discharge the patient from the PACU is based on written discharge criteria. A standardized scoring system, like the Aldrich scoring system, may also be used in determining the patient's general condition and readiness for discharge from the PACU. Before discharging the patient from the PACU to the clinical unit, you provide a verbal report about the patient to the receiving nurse. The report summarizes the operative and post-anesthetic period, and it should also include information as to where family and caregivers are waiting. If you are the nurse who receives the patient on the clinical unit, assist the PACU transport staff to move the patient from the stretcher to the bed. Take care to protect IV lines, wound drains, dressings, and traction devices. The use of a draw sheet, transfer board, or sling and sufficient staff facilitates the safe transfer of the patient. Obtain vital signs and compare the patient's status with the report provided by the PACU. Documentation of the transfer is then completed, followed by a more in-depth assessment. Postoperative orders and appropriate nursing care are then initiated. Ambulatory surgery accounts for 70% of all surgical procedures in North America. It has many advantages, including greater patient convenience, lower rates of hospital-acquired infection, and reduced costs. Ambulatory surgery patients include those patients receiving Phase 2 and extended observation postoperative care. The patient leaving an ambulatory surgery setting must be mobile and alert to provide a degree of self-care when discharged to home. Postoperative pain, nausea, and vomiting must be controlled. Overall, the patient must be stable and near the level of preoperative functioning for discharge from the unit. At discharge, teaching specific to the type of anesthesia received and the surgery provided to the patient and caregiver is reinforced with written instructions. The patient may not drive and must be accompanied by a responsible adult at the time of discharge. Patient and caregivers must have information regarding care of incisions and dressings, actions and possible side effects of any medications, activities allowed and prohibited, dietary restrictions and modification. Preparation for a patient's discharge should be an ongoing process throughout the surgical experience that begins during the preoperative period. The informed patient is prepared as events unfold and gradually assumes greater responsibility for self-care during the postoperative period. As the time of discharge approaches, be certain that the patient and any caregivers have the following information: care of incision and any dressings, including bathing recommendations, action and possible side effects of any drugs, when and how to take them, activities allowed and prohibited when various activities can be resumed safely, like driving a car, returning to work, sexual intercourse, leisure activities, dietary restrictions or modifications. Symptoms to be reported are like fever, increased incisional draining, unrelieved incisional pain, discomforts in other parts of the body, where and when to return for follow-up care, answers to any individual questions or concerns. Common reasons patients seek help from discharge include unrelieved pain, need for advice about medications, and wound oozing and bleeding. Attention to complete discharge instructions may prevent needless distress for the patient and caregiver. Written instructions are important for reinforcing verbal information. You must document the discharge instructions in the medical record. For the patient, the postoperative phase of care continues and extends into the recuperative period. Assessment and evaluation of the patient after discharge may be accomplished by a follow-up call or by a visit from a nurse, like a home health nurse.